most common cause of hyperthyroidism is Graves' disease. This is where you have an IgG antibody that stimulates the TSH receptor. When you stimulate the TSH receptor, you increase the production of thyroid hormone, and you also increase the release of thyroid hormone. So two things are going to occur: increased production plus increased release. This is the most common cause of hyperthyroidism, as I've already stated, and it classically occurs in women of childbearing age. Again, this is the classic demographic for an autoimmune disease. Clinically, the patients are going to have hyperthyroidism. Again, you have increased production and secretion of thyroid hormone. They get a diffuse goiter. As this antibody is stimulating the TSH receptor, that's going to cause massive hyperplasia and hypertrophy of the thyroid diffusely, resulting in a diffusely enlarged thyroid, and the word goiter refers to an enlarged thyroid. And they get exophthalmos and pretibial myxedema. Now, this is very important to note and very high yield. This is not due to the hyperthyroidism. It is due to the fact that the patients have an antibody that stimulates the TSH receptor. So the idea here is that the fibroblasts behind the eye, as well as the fibroblasts over the shin, they have TSH receptors. And so in response to this antibody, they actually begin to secrete excess glycosaminoglycans, which then results in exophthalmos because the eye gets pushed forward, and a pretibial myxedema. Edema here refers to the fact that it looks like there's swelling of the tissue, but the word mix refers to the fact that it's not due to water, but instead it's due to glycosaminoglycans, or a mixoidy substance. And clinically, they classically describe this as a dough-like appearance, so that when you press over the shin, you actually can feel a dough-like consistency to the tissue. Here's a picture of Graves' disease. You can clearly see that this is a goiter, an enlarged thyroid, and you can see that it's diffusely enlarged. This is a histologic image taken from a thyroid with Graves' disease, and you can clearly see that there's hyperplasia of the follicles. Notice how large they become. One of the very high-yield findings here is that you also get scalloping of the colloid. In order to understand this, look at this follicle here that I'm outlining. This is normal. Notice that the colloid in this follicle, the pink material, is totally up against the blue epithelium, with no really clear white space. However, notice that in this follicle here, you clearly have epithelium, but you've got this white space in between. And this white space kind of appears scalloped like this, and so they call that scalloping of the colloid, and that's a particularly classic finding in Graves' disease. Now, of course, these patients are going to be producing excess thyroid hormone, so there will be both an increase in total and free T4. The TSH will go down, and that's because the free T4 will downregulate thyroid-releasing hormone receptors in the anterior pituitary. Recall that the anterior pituitary secretes thyroid-stimulating hormone, but only in response to thyroid-releasing hormone that comes from the hypothalamus. And so what T4 does is that it downregulates these receptors so that the anterior pituitary will then no longer be able to receive this signal and therefore will produce less TSH. The patients will also have hypocholesterolemia. I've already explained that. And they'll have an increased serum glucose. I've already explained that as well. The treatment for Graves' disease includes beta blockers. Again, you're trying to block the effects on the sympathetic nervous system. Thiomide is another treatment. This is a drug that has the ability to block peroxidase. Let's go back and remind ourselves, if this is the follicular cell of the thyroid, remember that the cell takes tyrosine and it converts tyrosine into thyroglobulin, and then the thyroglobulin is pushed off into the follicular lumen. This is where the colloid would be. And then at the same time, the cell takes iodide from the blood and brings it into the cell and then crosses it over to the follicular lumen where it undergoes oxidation and becomes I2. Remember that the thyroglobulin and the I2 are then added together in a step called organification, and that's going to result in thyroglobulin with monoiodotyrosine and diiodotyrosine. And of course, the mono and the di will be coupled together, and that's going to then produce thyroglobulin with T3 when mono and di are coupled together, or T4 when the di and di are coupled together. Now, important to note that all of these steps here, the oxidation, the organification, and the coupling, these are all catalyzed by peroxidase. And so if you block peroxidase, obviously you're going to block the ability to produce thyroid hormone. And so that's how thiamide works. Another possibility would be to use radioiodine to ablate the thyroid. The idea here is if you give radioiodine, of course, that would be taken up by the follicular cells of the thyroid, which would then result in destruction of the thyroid cells because of the radioactivity, and so you would ablate or destroy the thyroid gland. The thyroid storm is